Thank you, Dr. Arul Saranan. I think we need to have the question and answer session. It is after the presentation. Fine. Now it is time for Dr. K. Raman.
Good morning. Good morning, everyone. At the outset, I would really like to thank IPS South Zone and Tamil Nadu chapter of IPS for giving this opportunity. And not wasting much of time, I thank Dr. Arul because he just made the job easier, because there are certain general rules for handling exams. I think like he has just made it very clear. I'm just going to be more content specific for the practical exams, clinical exams, so that like where all students are likely to actually make mistakes and what are all the common errors that are actually done during the clinical exams, how to avoid it, so that it's easy to actually like get geared up for the clinical exams as well. So what is one factor which will affect the outcome in the clinical exam? Maybe you can say many factors, but most important factor, or can you come up with some factors which will affect the outcome in clinical exam? Staying calm. So you have already cleared your or just completed your theory exams and you are actually like waiting for the clinical exam. Many times like students have this thought process that like theory somehow 10 short notes, the examiners will give marks and somehow we will scrape through the 50%. But the clinical exam is something like that you have to actually perform and show in front of them, right? So like the performance anxiety is one component which will impair our ability to actually, even though you have read so much, on the day of the exam, our anxiety is definitely going to impair or reduce our like ability to actually score better. So most important thing is like stay calm as much as possible, relax, revise, and go into like a proper planning stage for how you will go about handling this exam. So these are all just general tips, but I'll just go into core content and specific areas. Yeah. So as it was told, for the preparation stage, so for theory you have some different ways. So how do we actually prepare for clinical exams? So generally I would recommend that like you will be out of bounds for exam. So universities will have policies and institution will have policy that you are not supposed to be actually in the campus after the theory exam, or like you should not enter the ward. Those kind of, it applies to varies from institutions to institution, but out of bounds is one concept that students have to remember. I remember my professor actually used to actually bring cases on, so that like nobody knows like what case is being kept in the ward, and students will just come to know about it well in advance. Am I audible? Am I audible? Okay. So what he used to do is like, preferably if it is a Monday exam, Saturday he would go for a community camp which is attached to the institution. He'll pick up all cases with good psychopathology and they'll all get admitted on Sunday. Okay, only the skilled assistant will know the cases. Okay, so such things also happen, so that like there is some objectivity to examination. So clear objectivity to the examination is what our professor used to actually do. So, but like there are many institutions where many students are aware of what all the cases generally kept, so that they don't have to get anxious about it, but at least they need to gear up for the like how to actually present and improve their presentation skills. So nothing comes on the day. Please remember, nothing will come on the day of the exam. So it is all comes only with practice, revision. So present exam oriented cases and get feedback. So maybe for 3 months, at least I would say like 1 to 2 months, like 3 months before itself. Generally there is a tendency for like focusing on final year exam going PGs. As soon as they entered into third year, as soon as they have submitted the logbook before 6 months, the last 6 months it's exclusively focused on preparing them for the exam. Many institutions follow this policy. So I would suggest that like they should start presenting exam oriented cases. Of course, but till then they would have got exposure to all the cases, but just start to become more confident, okay, on the day of the exam, okay, and get feedback. The most important thing is not just getting a feedback, The important thing is going and corrective learning is important actually. So if some correction is given, okay, you will have to improvise on this, then that has to be go and just changed. Make diagnostic formulation for cases and management plan. That is very important because that will never come on the day just like that. Only if it is practiced, it will come. Okay, it's not just like randomly on that day, I'll just like figure out some diagnostic formulation for that case. No. So please just make diagnostic formulation for cases, whichever you are presenting during that last 6 months. And for every single case, you will have to actually do this as a practice diligently. Interview patients in front of your faculty and get feedback on phenomenology elicitation and interpretation. This is very important because many a times, like in the examination for clinical exams, you'll be asked to interview. Many examiners have the tendency to call the patient and clarify phenomenology in front of them. So please just like get this practice that like, so that when somebody is observing, generally there is a tendency that like evening you will clerk the case when no faculty will be supervising you, right? And the next day morning you will be presenting the case. Some institutions have this policy that calling, but like the faculty themselves will interview. But some have the tendency that like the postgraduate has to interview and elicit in front of them. If that has been a regular practice, the anxiety is going to be less. But if that practice is like less, then please just like ask and then like present and interview, so that like even during the ward rounds, there are senior faculties who will say like, okay, randomly just ask, okay, elicit. So you will be in front of the juniors. So this is all to curtail your anxiety. So that like on the day of examination, if you are interviewing in front of so please don't think that like, okay, this is going to be somebody is observing me, I'm likely to make mistakes. That should not be the pattern of thinking. It should be like you have already done this and it's just that like somebody is going to observe, the person is different. That's it. Okay. Apply theory to clinical practice on a daily basis. This again comes only with practice. That's why day one is important. And at least 6 months is important. Okay. It doesn't come just like that. So please don't see theory and practice separately. Theory and clinicals are like integrative. So if whatever you read in theory, you should be able to apply to the clinical practice. That is what like the standard teaching process will be always. Okay. So like randomly theory guidelines alone is, some students have this tendency to rattle out treatment guidelines. But when we ask them like, can you individualize this for this patient? They will struggle a lot. Because that integration has never happened even during that practice. So it is always important that whatever guidelines, whatever psychotherapy you read in theory has to be individualized and applied to the patient that you are actually seeing. Focus on the preparation rather than the outcome. So that's more important. So like give your best, and that day is not going to be a very detrimental day as like taught by many people. So it's just like, it's like learn to cut down anxiety in your own ways, like figure out some ways to calm down yourself so that you just give the best on the day. Please remember that no examiner comes with a tendency to fail any candidate. So this is a general tendency that like it is changing, that most of the examiners come with a good intention to actually evaluate the students' overall clinical skills and how they are able to, how will they be able to handle a patient when they are actually going outside to a private practice or to the community. So that is the overall intention of the examiner, not to actually scrutinize and find out like those olden days phenomena and all is like getting slowly just diluted. But like there are examiners who look at really quality. So please just be prepared for that. So let's get geared up for good quality preparation. This is not just for impressing the examiner on the day, it's basically for our future. Okay, so this is the exam format. Okay, like there will be long case, psychiatry long case. I'm sure like it will vary from institutions to institutions, but as far as the NMC guidelines also goes, practical examination, like there is a definite psychiatry long case. And as far as they have told, it is a short case in psychiatry and short case in neurology, which is mandatory. The rest all is you can actually decide, and the viva voce. Okay, logbook, thesis, dissertation can be evaluated, should be evaluated as part of by the external examiner. Okay, so remember, psychiatry long case, in some places there is a medicine short case which is kept. Okay, in some places, I'm not saying that in all places, but psychiatry short case and neurology short case is mandate. Viva, in some places we have OSCE stations. In places like CMC, I've heard that there is something called as ward rounds, which is usually part of the DMB examination. But like ward rounds are not part of the MD psychiatry examination, to my knowledge. If there are states still following, I just thought I'll just add that also. It's always better to know what are all, see, I'm not saying that I'm narrowing down to this, but basically what happens is, like, as we are actually pulling out, we know that like what are all the possible long cases that are kept. Okay, so this is just to know that, like, okay, we are more fine-tuning our preparation, but you need to prepare. Theory, you are broadly prepared. Clinically, you are just going to narrow down. So this is basically also to reduce the anxiety for people who are more anxious about presentation and all those things. Creating a mental template or a clinical template on the day of examination. So probably if the patient is going towards a psychotic spectrum, what all I should not miss out in the history, what all I should not miss out in the examination, what all I should not miss out in the MSc. That is why I've just put this possible long cases. Okay, so generally the long cases are this. If there is treatment resistance, depending upon the availability of the cases also, it can vary. So generally long duration histories and with comorbidities, that is the norm actually. So no, if there is comorbidity, definitely long case is ideal. And if there is like recurrent depressive disorder, or if there is delusional disorder with comorbid depression, so these are all the possible long cases actually that is considered. But just remember, always remember comorbidity, or where there is a differential diagnosis, or if there are a treatment case where there is scope for discussion. These are all the possible cases that you need to think and just get prepared for that. Okay, fine. So always remember that, like, as apart from the general instructions on the day before examination, apart from this, so like remember that cases with good psychopathology, this is general anxiety for the students, cases with good psychopathology only will be kept. Don't think that, oh my god, like what if the patient doesn't open, what if the patient actually doesn't come out with the phenomenology. Okay, so what if the informant is not giving a good history? Do not have to get worried about it, because the role of the skilled assistant is to ensure that they have good psychopathology, the patient is cooperative, and the informant is also, because it's just going to be 1 hour, and I think that is more anxiety provoking than anything else, to complete this task in 1 hour. That's why I've given a rough actually split up. I know it is very, very difficult, but just when you are preparing itself, you should prepare for this timeline. Timeline is very, very important when you are preparing itself. Okay, always follow the proforma used in your institution. As just from people who have attended yesterday, just remember that there are variants of the history proforma, like which might be used in your institution. Follow the proforma that is used in the institution. So the internal examiner will be able to substantiate, saying that like this is what we are following in our institution. So you don't have to worry about it. Okay. But if you are missing out on your own proforma, that is what you need to actually have a check on. Okay. So plan your timing. So as soon as the case is allocated, generally the examiner day, like you will be all called, introduced to the examiner, and examiner will be generally easing out the students, because they know that the intention is not to create anxiety, the intention is to make you perform better. Okay, so please just remember that, and most of the institutions follow this policy. Okay, have some mental timing, and so that like almost 20 to 25 minutes for HOPA and other history, and 10 minutes for physical examination as relevant. So please just plan it in such a way. So this is all something to do, be like very crisp, and you should plan it. Okay, almost 15 to 20 minutes for mental status and higher cognitive function, and 10 minutes for formulation, management plan, and prognosis. Okay, this is one point I just thought it will be useful. Many students have the tendency of writing the history. Okay, if you take time, it is all your smartness. Individual differences are there, so it is all your smartness. You can write, then only I can actually come out while presenting. If you are used to that, you can do. If you are thinking that it is taking time, then you can jot down the points, because nobody is going to actually ask your paper and correct that paper which you have written it. So it's all yours. How you want to go with the flow, please just proceed with that. Okay, so don't think that, oh my god, I have to write it and give. Clarify all those things from the examiner instruction point of view, and then carry out. Okay, avoid these don'ts. Okay, so like do not miss out on relevant negative history. So there's something called positive and negative history. I'm sure you must be knowing there's something called positive, negative history, which is relevant to the probable diagnosis that you are arriving at or hinting at from the HOPI, and the negative relevant history, rule out all other conditions like organicity, like anxiety, comorbidity, so whatever it is. Okay. Examiners very well note down that because they will be given a list of the cases with their summary also with all the positive MSc findings. So they will have. Examiners also will interview the patients on the day of examination before allocating the cases. Okay, so they know the case. It's not that like you can cook up something and say something on the day of the examination. Okay, something you can just randomly elicit and just like not present, or if you have missed out on important things, that will also be taken into consideration. So please, general instruction is do not miss out on history of suicidal attempts or any high risk situations. And focus on, don't miss out on impairment or ADL or biological functioning. Okay. And also focus on eliciting in case of episodic illness, past history and hospitalization, and some cases where there is a postpartum exacerbation. These are all just subtle things which we might miss, but if at all you are making a clinical template and just preparing, definitely you will not miss out. Forensic history, wherever appropriate, just ask where there is legal litigations, do not miss out, because the case summary will be given to it. So in case if it is out of anxiety or missed out, the examiner will definitely give a clue on asking it. Okay. So what else would you like to actually consider? What else would you like to answer? Like that, they will be giving the clue. If they have it, but you have not elicited it. Okay, don't just get upset or don't get anxious that, oh my God, I forgot to elicit it. Nobody will punish for that. So they will give clues. Most important is your internals will be giving clues. Okay, internal will be giving clues means, what do you think? How would you just consider this? What would you have asked in additionally if you have had more time? That will be definitely there. So please pick up on the clues from the internal exam. That means they are guiding you to the right thing. Don't get fixed, don't get rigid, and don't get like stuck with your opinions. Be flexible and open-minded at that point of time. Even if the examiners are telling you something, just be accepting, okay, fine, sir. Yes, sir, I should have asked it. Okay, that is what generally the norm is. Okay. Do not miss out. Many a times, relevant physical examination is missed out. Fundus examination is being repetitively asked by actually many of the examiners. But just, of course, if you have a CNS case, they will focus. But some examiners who are really looking at like overall comprehensive organicity also, they are just looking at. And please just remember all the visible scars, injury marks, don't forget. Because many a times you will say, okay, the chest examination, respiratory examination, S1S, all this CVS examination, normal vesicular blood sounds, abdomen soft tender, CNS exam, everything. But actually their patient would have had a superficial cut because of actually deliberate self-harm. You would have failed to miss it. Okay, so physical examination I did means I saw the entire patient. Okay, don't just like focus on only systemic examination. Thyroid where relevant, those things also has to be considered appropriately. Do not leave headings under MSc and HML. This is just a standard protocol. All MSc or everything should be actually focused. MSc is for past 1 week. This is just a reminder. And MSc cannot bring out anything that is not in the history. Please this is a standard rule that MSc cannot bring out anything which is not there in the history, because MSc is part of the history also, because it's inclusive of what the past 1 week is. Okay. Mental status examination, all the components try to cover. Generally, the students make mistakes is like mood, they will say like, and they will not elaborate. And affect, they will say they will not be able to elaborate on the components. Speech components, just be very thorough with the proforma. Okay, that is the very basic standard expected. Follow the standard proforma that is being actually followed. And for higher mental functions, actually, please follow Strub and Black. Okay, Strub and Black, Fish Clinical Psychopathology for definitions, and Bicester for neurological examination. All standard books revision is mandatory before the exam. Okay. This is common area like where people always ask questions. Neutral topics for speech. Always there's a tendency that Diwali, one student will come and say Diwali, other student will come and say Diwali. A lot of neutral topics you can actually just like explore on the neutral topics. Okay, just not this festival is the only neutral clause. The place that they visited, that if it is a household woman, the serial that they usually like to watch. Okay, so anything. Okay, so you can actually think of that, because generally on the day you will have little difficulty. This is another area where students find it difficult, because generally what they do is, I give 5 proverbs and 5 pairs for actually similarities and dissimilarities. That's all. And leave it open. So because make comment on the interpretation, abstract thinking impaired. Abstract thinking is at the concrete level or the semi-abstract level, intact, attention aroused, concentration sustained, comment, interpret, recent memory impaired. Okay, tell what you did and tell the interpretation. Intelligence, there's always this question, just like how is intelligence from the history? From general information, arithmetic ability, comprehension. So these are all that's routinely asked. Okay. Of course, diagnostic formulation, please, it's just by practice. There is a difference between summary and diagnostic formulation. Yesterday we just had a discussion, but like just practice and get feedback from your own faculty. Differential diagnosis is must, because many examiners will look for how you are actually alternative thinking and critical thinking. Okay. They don't want, we know very clearly this case of schizophrenia. Now, what is the alternative diagnosis that you want to consider? Just come out with differential diagnosis when you are practicing and presenting itself. Please develop this habit, okay? DD is different from comorbid diagnosis. Okay, a patient can have major depressive disorder with obsessive compulsive disorder. You cannot give MDD versus ODD as differential diagnosis. I hope you understood, okay? Management plan. This is very important. Individualize. You see that patient, what will you manage? Generally, students will tell, okay, I will start with this drug. If not responding, I'll go with this drug. If not responding, treatment resistant, I'll do this, I'll do this, I'll do this. So you don't get caught. Just ask and focus on what is the examiner is asking. Do not go beyond. If you do not know, accept I do not know. Okay. Answer what is asked by the examiner. That's most important. Many times you just like lead something and the examiner will ask questions and then you are stuck. You have read about some IPSRT somewhere in the theory and you want to say, sir, bipolar affective disorder, I want to start with IPSRT, psychotherapy. How many IPSRT you has done? That will be the next question. Can you just tell me how would you do IPSRT for this patient? Interpersonal social. You're stuck. Because we have never translated that into clinical practice. So that is what is individualized. So always do simple things, psychoeducation. Start with psychoeducation. So this is all the general norms. Please just like practice that in that same way. Follow this. Generally, there is a focus on MHCA section for admission. Many of the examiners ask this MHCA section. So please be aware of this MHCA section. Lab investigations relevant and you will have to justify. Psychological assessment, know the rating scale and also know what are all the possible findings that can come in a particular case. Okay, rating scale score is very, very important. If at all you are committing, please be prepared. If I am saying BDI, then what is mild, severe and moderate in BDI? Okay, if I am saying HDRS or Hamilton Depression Rating Scale, then I have to know. If I am saying Montgomery Asperger's Rating Scale, then I should know. Okay, so like that, randomly I'll just commit some rating scale on that day. Okay, it cannot be. Whatever you have applied, you please just remember that. The best way to do it, I will say, is for basic things, like at least remember like few drugs, complete mechanism of action and the dosage should be known. Maximum dosage reach, possible side effects, monitoring as per the Maudsley guidelines. Okay, or any other guidelines, standard guidelines that you would commit. Similarly, for psychotherapy, this is the therapy, basic psychotherapy. I will just do this. I will do it in this particular way is what is better. Okay. Of course, come out with all the prognosis factors, like also when you are actually preparing. There will be additional time. The first candidate is going to be the problematic candidate. The most anxiety provoking is for the first candidate. The other candidates will have time. Yeah, I'm just finished. So other candidates will definitely have time. Okay, so you all will have time to just organize your thought process and do. The first candidate, don't think that like, okay, there will be, definitely they will consider if you are stuck by 1 hour and you wanted some additional 5 to 10 minutes. But you cannot take 1.5 hours. That is up to, they will not allow that much time. So 5 to 10 minutes leeway is always accepted. To quickly just run through the other areas, the most important thing, remember for short cases, you are given either 20 minutes or 30 minutes. Do not waste time on history. No detailed history is required. Brief history, MSc, higher mental functions. Brief history, relevant like family history and past history, go directly to the mental status examination. In short history, you may be asked for eliciting mental status examination findings by the examiner. So be prepared for that. Okay. Or even if they have done it in the long case, they will skip here. So it's either way. Diagnosis, and generally the focus of short cases, like long cases, inpatient management, evaluation, follow-up. Okay, so sometimes they may even ask like, if this patient is admitted under you, how will you decide on discharging this patient? Okay, so you need to have a plan for that. Okay, so but short case focus is basically, if the patient comes as outpatient, how will you manage this patient? So that is the focus generally. Okay, these are all possible short cases I've just put. Coming to neurology, remember to carry the kit. Please remember to carry the kit. That is one thing like many people just forget. Sir, I don't have like the whatever fundoscope or orthonoscope, whatever it is. Just carry entire kit. Okay. Learn by doing while practicing. Please just like go, perform and do, and then practice. If there are corrections, just ask them to actually, because the neurology examination is just 2 minutes. Neurology examination is like, entire examination is focused on only making you perform or demonstrate. That's it. General tendency is that, but there is usually the focus is on also psychiatric aspects of neurological disease. So there might be discussion on that. Say for example, post-stroke depression. Epilepsy means psychosis. So stroke, like Parkinson's means like they will actually go into the comorbid psychiatric illnesses. What are all the possible things and how will we evaluate clinically? That's most important focus. Okay. This is one of our website which Savita Medical College has created, and entire videos are uploaded for neurological examination and then like psychological tools. This is by like very standard professionals, neurologists. They have taught how to actually demonstrate actually the signs and reflexes. Medicine short case, very rare, but at the maximum you might get like ascites, portal hypertension and DCLD, and brief history and a detailed physical examination. That's very, very rare. In case if it is there, I would say that like generally there is a tendency to pick up alcohol as a short case in medicine. Okay, that's a general. So you'll be mentally exhausted by 2 o'clock. If there are more than number of examiners, the examiners are also exhausted. The first candidate gets the maximum number of questions, and as we progress, if you are the last candidate, I know like what will happen. But generally objectivity is maintained, so that like the timing is what is followed in many of the institutions. So if each candidate has to be questioned for 15 minutes, they will question for 15 minutes, most of the examiners. Okay. Gear up for noon session after snacking. Generally, school students would not have had their breakfast, or they would not. Even in between, if you go and just kill the assistant says that like, have some juice. No sir, no sir. Like they'll just all be like, just have something, because then only you can actually appear for Viva. Done sir. I'll just finish do's and don'ts, and then summarize. I'll just share this. So to summarize, know the basics thoroughly. Okay, and quickly revise the criteria. ICD-11 is being asked by many of the examiners, so please just like have a knowledge on ICD-11. Definitions, quote standard textbook of reference, and quote standard treatment. Don't say that like random guidelines just like that on that day. Quote standard text. Know the starting dose and maximum dose of drugs. Always quote on the drugs which is practiced commonly in your institution. Examiner looks at your skill of approaching a patient rather than like they don't look at like, okay, how will you diagnose complicated diagnosis. Don't get nervous if the patient is tired or less cooperative. Sometimes do not get carried away by the clues. See, the clues have to be taken as, oh, how I have to organize. But just don't just get carried away and that like get fixed and stuck. How my patient presented is what is the justification in front of the examiner. Do not argue. Generally, if you say that like your answer is right and just like try to just like justify, tell it in a nicer way. Don't forget to take cues from your internals. Remember, it's a day of your cumulative learning of your 3 years. Just be confident of your performance, and it's not the day for final decision. Okay, so just be confident and then you will be able to at least. The one thing is Viva portions, I will just circulate it. These are all the possible areas for Viva. Like generally it is divided, okay, and across examiners, 4 examiners are there, means they will divide the topics and you will be questioned on that. Remember to read on your research methodology, thesis topic, dissertation, and one more thing is the theory questions asked. There are few examiners who are interested in looking at the theory questions and they will ask, did you attempt this question? Okay, and there are few examiners who would have told that morning you read this and come for the Viva, afternoon please go and read that and then come for the Viva. Thank you so much.
Thank you, Dr. Arul Saravanan and Dr. K. Raman. It was a mind-blowing and comprehensive presentation of do's and don'ts with regard to the examination. I have seen so many interested and very serious postgraduates who are listening to you very carefully. I hope this will be a great inputs for their future exams. I even see here a few PG teachers who are also finding this presentation very helpful, because I believe in all institutions this kind of presentation should be done to the exam going PGs by the respective PG teachers in their institution. That will help a long way. With this, the floor is open for questions. There is from the IPSOCON organizing committee, for the best question raised by the audiences, there will be prizes too. I hope PGs will utilize this forum for their doubts and any questions.
We have about 6 minutes, so I would urge you all to quickly ask the question. Thank you.
In MSc aspect, for the personal and social, is it like we should include the historical aspect or just cross-sectional?
Generally, this was asked yesterday also. So generally the question is like, for social judgment, we should consider the historical aspect for sure. We will have to consider historical aspect, and because you would not have known the ward behavior observation. These are the two things that we take into consideration for social judgment. One is history. The second one is ward behavior observation and how he or she behaved during the interview. Okay, so these are the three concepts. But like we won't have ward behavior observation. So just take it from history and the others. Personal judgment, definitely it is from during the MSc. So what is your immediate future plan after discharge from the hospital? So whatever relevant answers we are getting, you will have to just apply and then like come to a judgment, like impression of the judgment.
So what if there is a significant language barrier between the patient and the examiner?
I think that is generally the tendency is, as you choose psychiatry, you should learn language. So any postgraduate who is taking up psychiatry, because we know that the art of interviewing is the core crux of psychiatry. So there is no, like information is like through communication only. So an empathy and rapport will develop only if the patient's language is actually known and all those factors are there. So definitely they need to actually learn the language at the end of 3 years. But that is left to the institution. If the student is actually doing very well, that like I think like the performances might be affected by the language, that can be an interpreter. But there is a plus and minus of this interpreter also. What you want to ask, what they ask, how they get back, all these are going to be difficult. So better thing is to learn by practicing, because I think myself and Dr. Arul, we did in Manital, so we learned Kannada, and then that is how we just presented in the final exam. So there are no interpreters given.
I request you to tell your name and then proceed.
Sir, my name is Anusha, sir. I have a question. So, like you said, the patient would be admitted a couple of days prior to the prior to the practical examination.
So he would have already gone like a round or two of questioning. So by the time he comes to us, there will be potential frustration or annoyance, and he would not want to give out all the information because in his head it's a cumulative process. He would think, why would I have to give every information to her? So that can result, by the time he comes to us, it can result in filtering of information and inconsistencies in history. So how do we overcome that hurdle in practical examination?
I was just giving the different perspective I was just telling, not to, I don't know whether you have just clearly understood it. Basically, I was just telling that, like, generally the patient is there for a longer duration in the ward, so they would have gone for multiple interviewing and then, like, it will be, that's what I told, the cooperativeness of the patient and from whom you will be able to elicit phenomenology, because they all know, examiners know, the skilled assistant will be actually told instruction by the HOD of the department to choose, and they will just interview and see that whether that patient will actually cooperate on the next day morning. There might be problems, some patients might become like the previous day night, some other issue might come up, okay? But they will always have alternatives. So you don't have to worry about that, because the patient cooperativeness and informant's cooperativeness is one factor that will be taken care by the skilled assistant. Okay, so I think generally they will go. And usually long case, there are 4 candidates or 6 candidates. Okay, usually long case, if they have to be given simultaneously, and then like they'll be given differently. And they'll be always given a break. Okay, patients will be given a break so that like they don't come to you immediately. And when they come immediately without break, then they might be actually exhausted, like how we get exhausted. Okay, but they are mentally, they are prepared, they are told that somebody will be examining, informants will be told that tomorrow you have to please just provide as much as information that you have told us. Everything will just happen from the institution side. So I think students need not worry about it. It's all that day, your ability, whatever you want.
Magil from CMC Vellore. One more question is, like, we have a tendency to present serial mental status examinations in case of maybe in DT, or in case of depression also. Sometimes the patient is absolutely not cooperative. There is a fluctuating situation like catatonia. How can we handle, for example, our scenario will be entirely different while we examining the patient. So will those cases be kept, and how it will be handled?
See, serial mental status examination is something that has to be carried out in the ward when we are seeing a patient on a regular basis. Here it's going to be 1 hour of examination. So just remember that complicated patients, disoriented patients, aggressive patients, violent patients, definitely they may not be kept. Generally, you would have come across a lot of patients who will be elaborating on their delusions to every person with the same amount of information. Also, that patients will, like the same questions you asked, such patients will be like talking, they will be willing to talk, they want to talk. So those patients are identified actually. So that is all from the institution perspective. I think generally it is not to make the student anxious, because we all know, and even if you have elicited something during your mental status examination, during the interview, and in front of the examiner, if you are not able to elicit that, you do not become anxious. At least whether you went about in the right way of questioning is what is being checked. Okay, that is what is most important. It's not about, one thing is interpretation of the answer, but whether you ask the right question, open-ended question, like where to ask leading questions. Those are all the things that are observed by the examiner. That's why OSCE is one thing, is also in some institutions.
I request only one question right now, last question.
I am Dr. Mulayandan from NIMHANS. Do we need to know all the ICD and DSM codes?
Not necessarily, but yes, of course, the common mental disorders, it is expected, since you are from institute and good school. you are expected that you would have seen a lot of these cases over your 3 years of training, and that by now, many of them are memorized. I'm sure nobody is going to penalize you for not knowing the code per se. And just to expand on what the other student was asking, right now there is a thought about continuing this exam, taking over this examination from a single day format to maybe a 2 or a 3 day format as well. Practical exams at least. Like for instances, even in paraclinical examinations like for MD pathology or MD microbiology, they have a 2 or 3 days practical exams going on. So our guru was of the view that this should probably be incorporated into clinical sciences as well, wherein the student is given a fresh case on day 1. He is given all the liberty to evaluate him on day 1, do all the investigations, and finally should be in a position to diagnose and manage and show improvement over these 2 or 3 days. So that is something which probably going on in future that might come about. But until then, I think we are good with this. Thank you.
With that, we come to the end of this session. I would request sir to please choose the best question.
I request our today's speakers to choose the best question because they know they are the experts in the subject. There were 4 questions.
I think the practical anxiety that is running in students' mind, I would say that, I think she raised that question.
I think
that is generally the practical anxiety of the student on the day of the examination when we are examining a student. I think I would
I was also sailing on the same boat.
go with her actually.
Yeah, maybe. Congratulations.
I would like to thank South Zone and IPS company and Zonal Branch of IPS and Dr. Adil Saravanan, who really actually made the process very simple and being my co-speaker. And my team, I wanted to thank Dr. Lamia and Dr. Nidya, who will just come up with some information on the document process.
Thank you, sir. It was a very insightful session, as we can see by the number of people in the audience in this boardroom. I would now request the speakers to kindly come to the end of the stage so that we can felicitate you, sir.